So glucose is the primary fuel for the fetus, and it accounts for 80% of the fetal energy consumption. It is interesting that the glucose is not produced at all by the fetus. Of course, in some situations, extreme situations, experimentally, it has been shown that if the maternal glucose supply stops for more than 24 hours, the fetus may start neoglucogenesis. But in normal situations, the glucose is not produced by the fetus. It's fully dependent on the placental transfer. The fetal glucose concentration is approximately 70 to 80% of the maternal venous plasma. So in terms of the diabetic mother, for example, where the mother sugar is already high, the fetal sugar will reflect that. Insulin does not cross the placenta, and therefore the fetus must secrete insulin independently. And as you know, if there is a stress, the reaction is according to that.
Sorry, doctor.
So coming on to situations of persistent hypoglycemia. So we have so far looked at the risk factors, which babies you are going to screen. We clearly define that the well babies who don't have a risk factor, you're not going to screen them. We often tell the postnatal staff that babies often sleepy in the first 16 to 24 hours because they are using up their store, and you don't need to prick a baby to check their sugar just because they're not keen to suck. As long as they're responding normally when you handle them, you don't need to worry about a little sluggish suck on the first 24 hours because they're not keen to suck, because they're using their stores. They're also tired from the labor process. So a proper assessment is important, but avoid doing sugar just because the baby is not keen to suck if they otherwise look well. Of course, if you are worried that they are hypotonic, they are sluggish, you do have to test it. So that's where your experience comes in when you assess such babies. So for persistent hypoglycemia, we mentioned that we have glucose infusion rate to prevent hypoglycemia persistently more than 12 in a well-grown or LGA baby. Small for gestation babies may need that infusion for a short period because hyperinsulinemia, which is transient, is often seen. If we have evidence of hypothalamic dysfunction like unstable temperature or micropenis, as we discussed, profound hypoglycemia occurs unexpectedly in a well-grown term baby. Again, this could be hyperinsulinemia. If there are other associated factors like examphalos, for example, with Beckwith-Wiedemann or coloboma with midline defects, there's a family history of sudden death, Ray's syndrome, developmental delay, and so on, if there is anything suspicious of an inborn error of metabolism. So you can categorize these as hyperinsulinism, where it can be congenital hyperinsulinism, a syndromic one like Beckwith-Wiedemann syndrome, or you may have endocrine problems which include pituitary insufficiency, cortisol deficiency, congenital glucagon deficiency. You have epinephrine deficiency as well if the medulla is not well formed. And we have IEMs, which include carbohydrate metabolism ones like galactosemia, hepatic glycogen storage diseases, fructose intolerance. We may have problems with amino acid metabolism like maple syrup urine disease, propionic acidemia, methylmalonic acidemia, tyrosinemia, and so on. And we can have the organic acidemias, glutaric acidemia, methylmalonic acidemia, and problems with the fatty acid metabolism like carnitine deficiency, acyl-CoA dehydrogenase deficiency. And we may also have neurohypoglycemia by defective glucose transport protein. So the diagnostic workup when you can suspect persistent hyperinsulinism is to do a critical sample, but we have a pathway for that, which I will discuss. So we mainly need the plasma insulin ketone bodies, which will define whether it is ketotic or non-ketotic hypoglycemia, and we need free fatty acid levels to be measured. So if it is non-ketotic, you either have hyperinsulinemia or you have fatty acid defects. That's why for the non-ketotic, these two are needed. And most of the newborn hypoglycemia in the first 24-48 hours is going to be non-ketotic in majority of the cases. Additional tests may include plasma ammonia. This helps in organic acidemia. It also helps in hyperinsulinemia due to the glutamate dehydrogenase activating gene mutation. And plasma cell carnitine profile, urine organic acids, and then you start testing for the serum cortisol growth hormone for looking at hypopituitarism or glucocorticoid deficiency as well. The genetic testing will follow, and imaging will be needed like PET-CT if you're thinking of nesidioblastosis, that is to look at the pancreas. So the underlying cause that you think is the reason, and the severity will dictate the approach to the management. So this is a busy slide, so I've broken it up. We have the hypoglycemic event, and the baby can be symptomatic or asymptomatic. If the baby is asymptomatic, you feed and monitor, and if euglycemia is achieved, continue the normal schedule. And if hypoglycemia persists, you may consider either feeding support or IV dextrose if it is not picking up. And if it is symptomatic, you give a dextrose bolus and go for the infusion as we discussed. If the hypoglycemia persists for a long time, or it's a very high glucose infusion rate as we saw in the previous slides, you have to obtain the bloods. If the hypoglycemia resolves, you monitor and discharge. So the bloods we obtain initially are the plasma insulin, free fatty acids. Of course, the free fatty acid test takes time. It doesn't come immediately. So you'll have the insulin and you'll have the serum and urine ketone levels. If it is a ketotic problem, it's a totally different branch. As I said, most of them in the beginning are non-ketotic. If they're coming from home with the hypoglycemic seizure, you could think of this category more. If they're in the hospital in the first 48 hours or so, this category is more likely, and many of these are transient as well. So you have the transient hyperinsulinism in the IUGR babies, in the LGA babies, in the infant of diabetic mothers. Even in Beckwith-Wiedemann syndrome, the hyperinsulinism is transient. The persistent hyperinsulinism is where we think of the genetic mutations. So in the non-ketotic category, if the free fatty acid is low, you would have the insulin level by the next day. So you'll have a high insulin, which will put this baby to this category. So before the free fatty acid level, mostly we get the hyperinsulinism confirmation. Once you know it's hyperinsulinism, if it's not responding to your regular treatment, you give a trial of diazoxide. If the trial fails, then it's mostly the non-GDH pathway, and you may consider octreotide or octreotide plus glucagon. Rarely nifedipine can be used, and if it fails, you go for imaging for the pancreas with PET-CT and surgery based on what you find. Either a subtotal pancreatectomy, or if it's a diffuse disease, you have to do near total. Majority of the time they become diabetic after that treatment. If they respond to the diazoxide trial, continue the diazoxide with close endocrine supervision. If they are ketotic, then if the lactate is high, they become gluconeogenesis enzyme defects. And if the lactate is low, it may be hypopituitarism or hypocortisolism, GSD type 1 or ketotic hypoglycemia. So this is the simple way of differentiating hyperinsulinism. So you do the plasma insulin and you do the ketones. If the ketones are negative, you have hyperinsulinism as a very high chance. If hyperinsulinism is, if insulin is normal, so basically you have to do the insulin when the sugar is low, when it is below 40, and any detectable insulin is supposed to be high when your blood sugar is low. So normally you take more than 2 units as abnormal. So there are mutations which lead to hyperinsulinism, as we discussed in the very beginning. Most prevalent cause is a loss of function mutation of the potassium ATP channel, and this leads to profound hypoglycemia. This may also not respond to diazoxide. So we also have mutations of the mitochondrial enzyme GDH. This is an activating mutation, and glucokinase activating mutation also can cause a similar problem, because the ATP is constantly high, so the potassium channel is activated, and we have the depolarization causing the voltage gated calcium channel to be opening up, and the insulin is secreted in excess. We also have mutations in the hydroxyacyl-CoA dehydrogenase factor. So we have Beckwith-Wiedemann syndrome, we have a mosaic of Turn syndrome, Costello syndrome may be associated with hyperinsulinemia and hypoglycemia. And persistent hyperinsulinemic hypoglycemia is now a new term. We don't use nesidioblastosis anymore, and we call it PHHI. The previous term of congenital hyperinsulinism is also not used anymore. So this is a rare condition associated with persistently elevated levels of circulating insulin caused by hypersecretion of the pancreatic beta cells and absence of ketone production. And it may present in the first few days, or it may present later in infancy. Many different metabolic disorders can also lead to persistent hypoglycemia, and glycogen storage disease, disorders of gluconeogenesis, and fat oxidation. Thankfully, these are rare. The incidence of the mutations that we discussed here, it's about 30 to 50,000 babies, so it's not common. So more common is a transient hyperinsulinism that we see. So once you have hyperinsulinism, the treatment approach is to use glucocorticoids as a short-term measure. Most of us move away from using steroids, and glucagon can be used for a short term. If the sugar is low and you don't have access, it can be used by intramuscular subcutaneous or IV route. Diazoxide is not effective in potassium channel related problems, and it is effective in GDH activating mutation. The GDH activating mutation, the typical differentiating feature will be a high ammonia with the non-ketotic hypoglycemia. And diazoxide is 10 to 15 milligram per kilogram 8 hourly. Watch for fluid retention and hypertrichosis. Somatostatin analogs are used where it is diazoxide is not effective, and that can be used in 5 to 25 microgram per kilo per day, usually given 6 to 8 hourly. Calcium channel blockers are not preferred in babies, though it may help in some cases in short term, but in persistent hyperinsulinism, usually these are not effective. And of course, if you have significant persistent hyperinsulinism, you may need surgical treatment. A quick review of a case which I had faced a few years ago. This was a term baby born to Chinese parents. Mother was preemie, no gestational diabetes, and pregnancy was uncomplicated. Birth weight was 3.4 kilogram. Initial assessment was normal. The lactation consultant reviewed, and the baby was slow to suck but improving, and the relatives were comfortable supporting. There was a language barrier because these were Chinese parents and most of the family did not speak good English. The baby was discharged by 30 hours after this lactation consultant review. There was a weight loss of 4%, which was unremarkable, and baby was clinically normal. The baby presented to the ER after 48 hours. The baby had a scheduled follow-up the next morning. So they presented the previous evening with seizures, and the blood glucose was unrecordable. IV access was secured. Baby was given phenobarbital loading dose, and in the NICU, baby was monitored. Parents said the baby refused to feed on the breast after a few hours of reaching home, but they did not try to give any other milk. They did not seek any advice. So nearly 24 hours of poor feeding and reduced activity. I'm sure all of us have faced such cases sometime or the other. Baby did not have any subsequent hypoglycemia, and we just kept on IV fluids of 6 to 8 milligrams. The workup came normal, the metabolic profile, everything was normal. Cranial ultrasound showed some increased echogenicity in the posterior region. So the ultrasound was abnormal. It was already an established brain damage. Baby was discharged home after 10 days, was suck feeding, but the neurology was abnormal. MRI done at follow-up showed significant posterior abnormality in the brain, as you would expect with severe hypoglycemic brain injury. So parieto-occipital area where thinning of the white matter, thinning of the gray matter, and significant increased echogenicity in the white matter. The poor prognosis was explained. Baby was already quite abnormal at 3 months of age, had microcephaly and features of quadriplegic CP. The parents moved back to China, and we reviewed the events whether we could have done anything different. Unfortunately, the baby did not have, mother did not have any risk factors. Feeding support was offered. Maybe the language barrier was only factor, and parents probably not responding appropriately was a factor. So we're already at 10 o'clock, so maybe I'll try to run through this fast. So neonatal hypoglycemic brain injury is where persistent or recurrent hypoglycemia leads to cognitive impairment, vision impairment, occipital lobe involvement and epilepsy, and cerebral palsy and other sequel. The diagnostic criteria, or if you have documented neonatal hypoglycemia, you have ruled out other conditions which can cause brain injury like HAE, hemorrhage, and infectious diseases. And the clinical manifestations of symptomatic hypoglycemia have been noted, and we have brain injury confirmed on imaging. So the baby we had all these features. The threshold we discussed already, so I'll skip through that. And this is the Arkansas study that looked at the babies who had the blood sugar recording in the newborn period, and they were looked at as 10-year-olds. And obviously they had seen, this is the physiologic range that you can see. They didn't comment on risk factors, so we cannot categorize. Like sugar less than 35 was seen in 6.4%, less than 40 was seen in 10%, and less than 45 was seen in 19.3%. And later on, you can see that the correlation with the decreased probability of proficiency on literacy and mathematics was seen in 0.49. So the proportion is improving in obtaining proficiency as the sugar levels were improving for both literacy and mathematics. The child study is a very popular study, and this was done by McKinley et al. In New Zealand. This was by continuous monitoring of the glucose during the first week, and these are babies who are at risk for hypoglycemia by the AAP guidelines. Hypoglycemia was defined as any sugar less than 47 milligrams. At the 2-year assessment, the neurologic assessment, the BSID, everything was normal. They did a subgroup analysis, and the more time the glucose concentrations were outside of the range of 54 to 72. So whether it is low or whether it is high, the neurosensory impairment risk and cognitive delay risk increased. So here the interesting part is the fluctuation is abnormal. So if the sugar drops or it goes very high, again it could be related to when the sugar goes very high, the insulin surge may be erratic, and that may be one of the factors. They also assessed the outcome at 4.5 years, and the cognitive, executive, visual, and executive functions, visual and motor function were assessed. The children who experienced neonatal hypoglycemia had worse executive, which means you have to think about a task and carry out something, and visual motor integration. They didn't have any other abnormality. The children who had the lowest mean and lowest maximum interstitial glucose concentrations had an increased risk. Again, it confirmed that both ends of the spectrum are not good. And other associations at 2 years of age were not apparent at 4.5 years. The pathologic changes in neonatal hypoglycemic brain injury, we have hypoglycemia disrupting the energy metabolism. So the brain cell softens and there is swelling and necrosis. The region that the injury is more is the parieto-occipital cortex, and basal ganglia, thalamus, white matter, posterior limb of internal capsule may be affected, and occasional small areas of hemorrhage may be seen. Once this injury is established, because there is cell necrosis, atrophy of the affected areas happens in the chronic phase, and there may be swelling in the acute phase. So the cortical cells are more susceptible to hypoglycemia because their energy consumption is more. The excitatory amino acid pathway like the NMDA receptor effect and glutamate excess, similar to in asphyxia, may contribute, and oxygen-free radical injury may contribute as well. We may have impairment of the glucose transporter protein in the brain as well. The reason the occipital protein and the posterior part of the corpus callosum and the optic radiation, these are the three areas which are more susceptible because axonal growth is rapid and this needs more glucose. The fourth lamina of the visual cortex is thicker, it has more neurons and synapses. This requires significantly more blood glucose. And posterior cerebral artery supplies occipital region, but it also supplies the brainstem, cerebellum, and part of the thalamus. So all these factors result in the predilection for the posterior part of the brain being affected more. Cranial ultrasound is useful, but it is difficult. In our case, we could see the brain injury maybe because it had established by 24 hours. CT scan is usually avoided in babies because of the risk and the specificity is quite low. MRI is more sensitive and specific, and we use specialized techniques like diffusion weighted imaging if they present acutely. MR spectroscopy may also be useful. So we have different pictures. So this is a typical picture we saw in the posterior region. We also have white matter injury. We have small cortical hemorrhages, and we have the posterior part of the corpus callosum involved here. And this is a more generalized involvement of the brain. So this will be a similar picture to multicystic encephalomalacia later on. So this is similar to the picture we saw in our baby where the significant gray matter thinning, almost no gray matter in the parieto-occipital region, and we have significant white matter densities. So very poor posterior part of the brain. The spectroscopy here, we look at lactic acid and the ATP. The ATP decreases and lactic acid increases in HAE, while in hypoglycemia, the ATP decreases, but lactic acid is normal. And the ratio can help differentiate subacute hypoglycemia and its sequel. So the last part, prevention of neonatal hypoglycemic brain injury, we have to support the breastfeeding and we have to monitor them appropriately. Don't assume anything, make sure they understand. Ensuring risk factor based screening, and in cases where IV treatment is needed, as I said, we do 6-hour provocative test, and the sugar should be more than 60. So where you have a doubt that there might be an abnormality, if you have needed more than 48 hours of treatment, or if there is a family history or any other pointers, you do this provocative test. It's better safe than sorry. Inadequate breastfeeding is more likely in situations like primiparity, unfamiliarity with proper latching and breastfeeding practices, postoperative pain, sedation, and discomfort in the mother. All these may interfere with early successful establishment. Your nurses also need to be primed. You need to make sure that the lactation consultants are spending time showing the nurses, because a lactation consultant is only there at certain times, but the nurse is there at most times. So train them so that they're able to correct any problems with the latch, they're able to support the mother, they're able to encourage them. They know the normal sequence, that the baby may not be that keen to feed in the first day, that the milk output is low on the first day, the importance of stimulating the breast to get the milk going, and so on. So this is an interesting one, that we assume that breastfeeding is a natural process and very few mothers will need support. But you can see here that in rural Ghana, only 4% of the mothers needed support with breastfeeding. But as you go to the cities, it goes up to 22 to 44% that need support. So it's not really that natural. You have to prime them in the antenatal period. You have to be ready to support them for the first 2 to 3 days. Once they reach the stage where the baby is starting to gain weight, the milk is coming, then you can leave them without supervision. So this category, this is a very big number, from 4% to 44%. That means every second mother who is primary needs significant support. And most of the families do not have much experience supporting. So you have to educate the family support as well. Grandmother is there, but she may not know as well. So all the breastfeeding mothers should have at least 2 supervised breastfeeding episodes before discharge, and they should have access to lactation consultant after they go home if possible, and education of both the parents as well as the team. And they should start very much in the antenatal period. Those discharged early before establishing lactogenesis should be reviewed within 24 to 48 hours. And this is the most important point. Though baby-friendly hospital initiative is important, all the healthcare professionals supporting the mother should be aware of the potential harm of the neonatal hypoglycemic brain injury. So the priority is to prevent brain injury where you have a risk. So BFHI takes a backseat when it comes to protecting the baby's brain. So the prognosis depends on the duration, severity, cerebral blood flow velocity, and the glucose utilization ratio. Prompt diagnosis and treatment can warrant generally good prognosis, and sequel include visual disturbance, hearing impairment, cognitive abnormalities, and occipital lobe epilepsy. A quick case, a term baby, 2.8 kilo birth weight, tremulous at 6 hours of age. Blood glucose was 32 milligrams. It didn't improve with the glucose gel and the feed, so shifted and started on IV fluids at 6 milligrams. It wasn't adequate, so it was increased in steps of 2. It crossed 12 milligram per kilo per minute. A central line was inserted as 20% dextrose was needed. Insulin was high. Urine ketone was negative. So we didn't need significant workup because we know it is hyperinsulinemia. This is a UGR baby, and other workup was negative. Baby was neurologically normal, thankfully. We couldn't wean the concentrated dextrose despite trying to improve the calorie intake by giving preterm formula and 2 scoops of Maxijule powder, which is a glucose polymer. On day 7, we discussed with pediatric endocrinology, and we decided to start disoxide at 10 milligram per kilogram per day. Luckily, we could wean off the IV fluids over the next 2 days, which is a good disoxide response. And because of the setting of transient hyperinsulinism, we decided to try and wean off the disoxide, and we could do that. Baby was monitored for a day after, and a 6-hour fasting glucose was done, and baby was discharged. Follow-up till 1 year is normal. So take-home points, hypoglycemic brain injury is a preventable cause of neurodevelopmental problems. It's very important to be aware of the high-risk groups, as well as a prompt recognition and management. So it's very important to create awareness with the breastfeeding team, as we discussed, and recognize the need for supplementary feeds appropriately. So thank you for your patient listening.